Great. Well, thank you very much for having me here. It's nice to be back to London. I don't know if many of you know that I did my residency here, and London was my home until 1991. I came here first to do emergency medicine as a fellowship, and there was a guy named Kerry Ferguson. I don't know if you recall. He was the head of the emergency department back in those days, and he looked up, said, "We're at South Street now, but we're only going to be there for one more year because we've got this new campus that's going to be up at Westminster, and you know, you're not even going to be, by the time you're here, we're going to be up there." So I'm glad to see the Westminster as I drove in. There it is. Sooner or later it was going to be there. I wondered whether I'd ever see it in my lifetime, but I'm glad that it's there. So thank you for having me. Turn on the slides. What I wanted to do is actually going to change after I've heard the conversation in a moment. I wanted to talk about establishing a culture of quality and our role as physicians in that context. But then I was told to give you a few examples of successes, and I thought I would give you some examples of things that are successes and failures, and because there's nobody that's a great success nor a great failure. But I'm going to spend a little bit more time on one project that I think is a prototypical health link, and it deals with specifically the issue of flow and vulnerable populations. So I'll spend a little bit more time on that, and I'll just run through some of the other aspects that I wanted to talk about before that. So first of all, the background, the context that we're speaking about. Why are we here today in the first place? What is the challenge that we're facing? And we've heard so much about the issue that our healthcare system is not sustainable. And everybody I would agree with that comment, but I would agree with it for a different reason. Healthcare costs in Canada, as we all know, about just over $211 billion. That's $6,000 per capita. That puts us about sixth in the OECD in terms of expenditure on health. So we spend a lot of money on health. In Ontario, that's about $44 billion, or 41% of our total expenditures in the province. So that's a lot of money. 11.6% of our GDP goes to health. Why it's concerning to people is not so much its absolute amount, but it's been growing at around 7.5% per year. In case you haven't noticed, revenues at the level of the provinces and the federal government are growing at around 3.5% per year. So we're spending more on health than we can actually afford. And that's why it's approaching a greater percentage of our provincial expenditures, getting close to 50% in some provinces. We're 41%. So that's why everybody says healthcare is not sustainable. I'd agree. That's a lot of money. If we've got really exceptional value for that, I would be a little less hesitant. But we don't get great value in many regards. And so the challenge is when you look at our comparators in terms of, I've told you about how much we spend, but how much we get as the population. Well, we sit about average amongst our comparator countries in terms of about 21 different predictors, and you've seen them and you've heard about them, and I had the opportunity of chatting about some of those predictors. But we're actually below in the lower 1/3, other than being average in most predictors, in two major areas, safety and the patient experience. And the patient experience equates to access. And so that's why we're sitting around today, because we're spending a lot of money on health services delivery as a province, as a country, yet our population, in terms of the value they're getting in return, is not that great compared to our comparators. So if you do the value for outcomes, the value proposition, we actually are in the lower 1/3. If you look at the Commonwealth Fund study, we're last. If you look at OECD, we're second to last because the Americans are in there. Thank goodness. So in that context, that's why we've heard, I think, it's unsustainable. We have to make fundamental changes, and that's why we're all sitting around this room today. So that's the context. But the trouble is, we're also going to have to make these changes in the light of several very significant challenges. An aging population. We've all heard that right now 12% of our population is over the, just turned 65 or older. Yet by 2030, that number will double. And we know that healthcare expenditures increase as we get older. But remember I said that growth is going at around 7% per year? The aging population accounts for 1% of that growth. Not a lot of it. Not as bad as we thought. Prominence of chronic diseases. Here's another one. By the time you're 45 in Ontario, you have an 80% chance of having one chronic disease. And of those 80%, 70% will have two or more. So we're seeing a population, age-adjusted, that has got more chronic disease than what we've had to deal with before. And I think all of us would attest to the fact that that's our clinical practice. Interestingly, I'm going to come back to the utilization and social inequity in a moment, but we're going to have to fix this problem in the context of fiscal restraint. Nobody's got more money. In Ontario, we've got a $12 billion deficit, $10 to $12 billion deficit. You're using 40% of the 41% of our healthcare expenditures provincially come from health. So where do you think they're going to find that deficit? They're probably going to look to health. We're going to have to do it without the federal government because the federal government feels strongly about classic federalism. But I wanted to talk about utilization because that was part of the conversation we had a little bit earlier at lunch, just before dinner, sorry. I said it was growing at 7.5%, and I said that aging was this gray tsunami that we're so worried about. That's 1%. Age-adjusted utilization. More diagnostics, more drugs for the same person, for the same illness, is going by 2%. Our drug costs, our diagnostics, our utilization as hospitals, etc. So the same person of that age is just getting increasing the amount done to them. And my challenge is, I'm not actually sure if in fact we're that better off because of that. I'd love to be able to say all those diagnostics, all those drugs are really making a difference. I'm not that sure that that's the case. Matter of fact, I have concerns in the patients I see. We may be doing more harm than good. So that's a big issue that we have control of. Second one is rising social inequity, and then I'll leave this section, but you might say, why would I talk about social inequity? What's it a big deal? We know that rising inequity between the rich and the poor, those people who are the poorest, there's greater social inequity, and with that comes greater health inequity. And it's said that about 25% of our healthcare expenditures go to those people who are the poorest. And in fact, their health outcomes are terrible. You go to the richest part of Hamilton, to the poorest part of Hamilton, the life expectancy drops 21 years. My practice is in the shelters of Ottawa. I look after the homeless of Ottawa. The likelihood that you'll get to the age of 75 in one of my shelters, 25%. The incidence of tuberculosis, HIV, hepatitis C are all higher in my shelters than where I work in Bangladesh and sub-Saharan Africa. So we have this inequity problem that's actually growing because the rate of social inequity in Canada is growing faster than any other developed country in the world. And so with that, we have this enormous cost that's going to be Anne, for example, that you just saw. Perfect example of the huge expenditures that are taking place. And I'm not sure if we're actually getting down to providing meaningful, effective care for Anne. Yet Anne, you can just see the cost. And I'll tell you about another series of examples because it relates to the topic of today. So that's our challenge. I'm going to go very quickly. We all know about the Excellent Care for All Act. This is in 2010, but it set the stage for Health Quality Ontario, and that's where the perspective I'm speaking from. But in this, they talk about the importance of patient experience. They talk about the need to make healthcare available to all Ontarians. They talk about accessible, appropriate, effective, efficient care. And they talk about creating and engaging all practitioners in a culture of quality. So that's where this whole legislative framework began. This is Health Quality Ontario. Just very quickly to tell you that there are three major pillars of Health Quality Ontario. The first one relates to defining the evidence, and they do a lot of evidence studies, the effectiveness of PSA screening, the effectiveness of vitamin Ds, the effectiveness of PET scan. Those were issues that were put to Health Quality Ontario. The QPPs, the quality component of that. What's the best practice for cataracts or congestive heart failure or stroke? All came from Health Quality Ontario. Not the pricing, but the best practice component. They try and support quality initiatives all throughout the province and trying to build capacity in quality. And they report on outcomes. And they report on our outcomes as we relate to our other provinces, as we relate to other jurisdictions outside of Canada. And they're reporting now down to hospital levels, and they're going to start reporting on primary care. And some of those factors, like how soon do you see people immediately after, those things might be part of a subsequent report card, because we're working with the primary care community now saying what are important parameters that you would like to see in a report card coming back for your information to see how you're doing in relationship to your peers. So, and these are around that are the people that we work with. I'm not going to spend any time about this. This is the mandate letter and other discussions, but you can see the priorities that are coming out of that mandate letter. Interestingly, you wouldn't, for those people who watch politics, mandate letters are generally not released to the public. And in fact, if you look at all the mandate letters, you see health showing up in social services, judicial, health, education. Health is in all of them. So this is a very health-oriented agenda that's coming forward. So it's an opportunity. But you can see where they're putting their focus, integration, accessibility. That's what you're talking about today. I would argue that as physicians, we have the responsibility, not just the opportunity, the responsibility to actually participate actively in this. And I've always said that if you want the healthcare system to be one that works for you and your patients, you better be actively involved in making it that way. And if you don't, and if your voice is not heard, then the health system may not necessarily respond to you nor the needs of your patients. So we must have a clinician body that's engaged, informed, effective, and accountable. And clinicians are, yes, they're primary care physicians, yes, they're specialists, but they're nurses. They're, I think almost all other disciplines, even personal support workers are right there. I think they're providing important aspects of clinical care. And we have to engage them all. And we have to have these communities of practice of like-minded individuals who come together, share information, and try and are focused on what's actually the best for their patients. How can they provide better care? Some of the questions around the tables today were, how can we, get at that? How can we provide the best care for our patients? And I'm always impressed with physicians and other providers that at the end of the day will disagree with about everything, but will always agree about what's best for the patients. And that's where we'll come together. So communities of practice, and that involves bringing them together for information sharing, shared or new experiences, shared resources, coordination, synergy, etc. And then engagement. So that's the second piece of this, is how do we get people who actually own this, who live it, breathe it. The successes of the system are their successes, the failures are theirs. They have to feel it. Too often, at least in my hospital, what we used to say was, that was the hospital. And when something went right or when something went wrong, we'd say, the administration. But what we have to recognize that we are that hospital. That's my hospital. And so when something doesn't go well, I have to feel that. So there's many different strategies that have been used. Some are funding, some are innovative programs with health links, and I'll tell you about that. Some are CME's development type processes. But in the end, this is about leadership. Standing up and effectively making changes for what you think are important. Now, I was asked to give several examples, and I'm going to quickly tell you about an engagement example, a community of practice example, but I'm going to spend much more time on a health links example, because these are all the things that we're talking about. So the engagement example, the one that I thought about, is what we've been doing at the hospital. Early on, we were impressed that our physician staff were not really engaged in the agenda that the hospital was trying to promote. They were just there. Sometimes they were in opposition, sometimes they were passive. Generally, they're passive-aggressive, knowing most physicians that I work with. Nevertheless, they weren't engaged. And so we actually did a survey, and we showed that about 25% of physicians were actually engaged in the affairs of the hospital. And we said, whoa, how do we actually, clearly there's this dichotomy, how do we actually think about that? So the medical staff took this on. It was not administration run. It was not top down. It was right from the bottom up. And the medical staff said, well, these are the things we'll deliver, but these are the things that we expect the hospital to deliver. So the left side is the hospital, the right side, you don't need to read them, but were what the physicians would deliver. Every physician at the hospital, 1,200 of them, has signed that agreement and signed it every year. And they rate the hospital on performances, on their ability to meet the left side of their engagement. So the hospital gets a scorecard. We talked to them, and through a process of discussion, we said, what were the things that would make you more engaged? And all the docs said, you better improve the culture of quality, define what your values are, allow us to buy into those values, engage us in the discussion of values. Align the hospital. Think of metrics to tell us how we're doing. At the same time, get into performance reviews. It amazed me. The most popular thing was improving in a hospital environment. They wanted to see increased access to resources for them to deliver service, not surprising. Second was, I want you to start reviewing performance. We must be subject to some kind of performance review. I think they were actually saying they wanted that guy to be subject to a performance review and not so much themselves, but nevertheless, performance review became number two. And then what they wanted to do is have some irritants that they normally experience on a regular basis, like calls, etc., addressed. So we went into all of those things through communication and engaging them in the discussion and promoting with recognition and rewards. This is our report card for the physicians. I'm the chief of staff. This is my report card. This is a report card of my department heads and division heads and individuals every year, and we have a performance review with a report card on physicians every year. With that, we've repeated the engagement survey, and now we're up to about 55% engaged. And if you talk about industry on these physician engagement things, a really good record would be about 70% engagement. But the good thing is it told us, again, areas that you could do to actually move the engagement strategy further. So by listening to physicians, engaging them in the discussion, getting them engaged in a values discussion about the quality of care, they came on side, and they've been very proactive. So I think that by and large, is a success. Very quickly, communities of practice. So how do you get groups of people together, like-minded, that really want to get things better? So how do the family practitioners get together? This is, NSQIP is the National Surgical Quality Improvement Strategy. So 2 hospitals in Ontario, 3 now, have participated, and now this is being rolled out to all hospitals in Ontario. This is voluntary, so it's not, it's up to those hospitals to participate, but it's being made now available to all hospitals. So surgeons can now be part of a quality improvement initiative. Their surgical practice is enrolled into that process. Their outcomes are measured, given back to them, compared against their peers locally, provincially, and internationally. And when we got the results, we're one of those hospitals. We are ranked, we actually ranked within the top 10 in terms of mortality. Unfortunately, we rank in the bottom 10 in terms of surgical site infection rate and catheter-induced infections. So we did terribly. We were called a rescue hospital. I'm not sure if we should be proud of that, but as a rescue hospital, a lot of people come in, they don't die, but you make them fairly sick in the process. So that led to us really trying to improve it. Our surgeons were great about this. They developed these CUSP teams, which were these quality improvement teams. They went down to these places, they looked at their peers who were doing incredibly well, and they came back and said, we've got to change the way we're doing things. They were engaged, a specific community of practice. It was driven by the surgeons, not by somebody telling them what to do. We gave them data, they wanted to fix it because that was what they were about. And now, I'm glad to say that that process is now rolling out across the province. So that's a good example of engagement and communities in practice. The last one here I wanted to just tell you about, and this is Anne. I didn't know Anne would be presented here, but this is my practice. And so we started what was called a health link before it was a health link. This is about 14 years ago. We started, we knew that our patients were coming to the emergency department, which this is our patients being the homeless individuals with drug and alcohol addiction and mental health. And those, we have about 1,000 every night tonight because it's snowing and incredibly cold. There'll be about 1,200 in our shelters tonight. Our program started off small with about 30 beds. Now it's the size of a medium-sized hospital. We have 240 beds. We have 85 personal support workers. We have just under 20 nurses. We have 3 physicians. And we provide hospital-based care on the terms of the homeless, so with the care they need, where they need it, when they need it. And so we provide hospital-based services in the shelters. So when I do rounds, every day I give oxygen, IVs, I do minor surgical procedures, I treat hepatitis C, HIV, I do paracentesis, we have a palliative care unit, we have all in the shelters. We have a managed alcohol program, an acute program, a residential program. We have a step up, step down from the hospital program. So these people, one of our guys, the worst I must admit, was in the emergency department, our emergency department, 191 times in 6 months before coming into the program. And as a result, we started the program, and now that person doesn't go to they don't go to the emergency department anymore. There's no need to go to the emergency department. We started to notice that many of our patients were coming up to the emergency department, fire, 911, ambulance, paramedics. They were drunk and disorderly at the Rideau Mall. I don't know if you know what the Rideau Mall, but it's very close to the homeless shelters. They're picked up, they're taken up to the emergency department. They're intoxicated, and they wait. They wait on the ambulance because they can't take people off the ambulance. I suspect it's the same problem here. We've got to wait for 5 to 6 hours. There'll be about 5 or 6 ambulances tied up that way at any one time. And then after about 5 hours of waiting on the stretcher before getting into the hospital, generally they sober up. And they may order a pizza or may just leave, and they'll just generally leave at that point without being seen. And that's the same story, day in, day out. Maybe once, twice, 3 times a week. And so what we did was we said, don't send those people to the police. The police don't want them in the lockups. Don't send them to the emerge, because what happens in the emerge is they just sober up, or somebody sees them and says intoxicated, exclamation, 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 detoxed, discharged. And that would be the result of that encounter. So we said, well, we'll take them. So we actually bring the ambulances to us. The police bring these individuals to us. The OC Transport, the bus system, brings these people to us. The other shelters bring these people to us. And so now we have a 46-bed detox, which we call TED, Targeted Engagement and Diversion. So these people then will detox with us in a supervised environment where we have oxygen monitoring, etc. And then in the morning, rather than just sending them on the way, we say, you know, do you really think you're going to keep raging like that? Why don't you enter into one of our managed alcohol programs or our treatment facilities for opioid addiction? Couldn't we give you some clean needles if you're for your heroin addiction? And couldn't we treat your mental illness? Couldn't we treat your physical problem of your sore foot or whatever you might have? And then slowly we enter them into our program or into supportive housing. And they just don't go that route into the emerge anymore. So that decants those same people. So I question, should Anne ever have gone to the emergency department? You know, should we bypass the acute care sector and put her into a supportive housing sector where there's meaningful ongoing engagement with mental health facilities, care providers? So the net result of that program was that we put 2 ambulances a day back into service in Ottawa and saved about $350,000. Our program saves about $3.5 million outside of our expenses every year. And we have better outcomes, not better outcomes, better targets than the house population. So immunization, self-care, compliance with expected standards of care. So the net result is that I think if you use a health links strategy towards vulnerable populations, high users, you can actually provide better care in a better setting at less cost. Care they needed, where they needed, when they needed. So that was a health link before it was a health link. I'd love to have gotten paid for that as a health link, but now we're already funded. So I thought I would end at that because I've been told that our time is up. The last slide, this is Tommy Douglas a long time ago, and he basically said, you know, Medicare is easy. That's not the problem. The first bit, what he called the first phase or the first wave, was really just funding, and he said that's easy. The hard bit is actually changing the healthcare system. And I think that that's what we're about today, the second wave of how do you actually make the healthcare system more responsive to our patients. And I would encourage all of us to get engaged in that process. I'll stop.